Thank you. Next, we have Senator Hyde-Smith.
Thank you, Chair Baldwin and Ranking Member Capito, and thank you, Mr. Secretary, for being here today. The concerns in Mississippi are very similar to many other states. Many hospitals are experiencing unbelievable financial and workforce restraints, and many have forced to cease services in order to keep their doors open. There's a hospital in the Mississippi Delta that has had to stop any OB intensive care units. All of that has to come to a close for them just to offer, primary care. But it's very vital because the closest OB is like 45 minutes to an hour away. So, but as they lose the ability to care for the more complex patients in their communities, the hospitals often have to transfer these patients hours away. And upon discharge, many of these patients require, of course, post-acute care, and long-term acute care hospitals and rehabilitation hospitals. They've become less willing to accept these patients without the backup of their local hospitals. So I'm sure you hear this all the time. But then the staffing challenges have significantly affected the ability for these facilities to continue on. And we're seeing longer stays in these other hospitals because the locals cannot back them up. But hospitals get paid on a diagnosis-related group payment, as you're well aware of, DRG, which typically covers a normal stay with that reflects the diagnosis. So patients are staying longer, and they're exceeding those DRG payments, and hospitals are losing money hand over fist. But more patients are boarded, so to speak, in the ER waiting rooms on emergency room beds, and they're just walking out of the ERs because without being seen. But they're held longer in their smaller hospitals while waiting for bed placements in a larger hospital. We have all these issues that I'm sure you've heard from many others. But how do we overcome a financial challenge that was made worse by COVID and inflation? Inflation that we are seeing not only in Mississippi, but all across the nation. And have you or the agency considered establishing a temporary per diem payment targeted to hospitals to help address this?
Senator, everything you've said, I have heard, not just in states like yours, but when I was further up north, in some of the northwestern states, they have large spans where there are very few physicians and healthcare providers. It's the same everywhere. Distance has caused a real issue. Telehealth was a saving grace during COVID, but that doesn't resolve it all. My wife, who's an OB-GYN, tells me about how in Sacramento, California, she will see patients who are coming from the very northern reaches of our state because the facilities there are not equipped to handle the needs of an OB patient. And so what you're speaking to is something that everyone is trying to figure out. How do we get resources and commitments into these communities? One of the things that we're trying, and we look forward to working with you on this if you're interested, is we're trying to make sure that graduate medical education slots, the slots where you send a resident to practice, that maybe we can try to get some of these into communities that haven't always had these teaching slots available, because the evidence shows that if you locate a student who's in the residency program, by the time they finish that residency program in that community, they often stay there and develop their practice there. And so we'd like to see, for example, if we can encourage people to locate in communities because that's where they're getting their resident training and have them stay there as a result. Other thing we're doing, again, small, but still can be helpful, our Public Health Service Corps. There are programs that we have that have loan forgiveness or complete deferral, where if you commit to 5 years of service in an underserved area, as you just described, we will pay for your 4 years of medical school education. And we're trying to do what we can to direct some folks into some of these communities. On top of that, of course, you see some of the money that's devoted specifically for rural healthcare providers. Still small potatoes overall, but it's an effort to try to keep those facilities alive.
So are you saying the temporary per diem is not being considered?
I'd have to get back to you. I'm not sure if that is one of the considerations. I would suspect that one of those issues with a temporary per diem would be the cost where would the money come from to do that?
But you would let us know if
Absolutely.
that's in the plans or if that's even something that anybody's working on
We'll
right
follow up
now,
with your
'cause
staff.
We hear from the hospitals and they're thinking that may be a solution, and they ask me, and I said, well, I'll have the opportunity to ask him, so I would appreciate it if you would
We'll
get
follow up
back.
with you.
And my time is out.